Are you guys seeing presenter view or are you seeing like the just the slides?
Uh,
Presenter mode.
Okay. Well, the screen here is showing just the slides, so I'll just keep it like this.
I think that's perfect.
That works for you guys. Cool. All right. Awesome. Move this one. Okay. Cool. Thanks for waiting. Sorry about that. My name is Harrison McUmber. I'm one of the resident doctors at the University of Utah. Thanks so much for having me out. Um, I have been traveling for the last 36 hours, so I'm a little tired, so I apologize. Also, all of my luggage got lost, which is why I'm wearing shorts and a t-shirt. So not looking as professional as I normally would. So I have no clothes here. Um, we're going to talk about diarrheal illness today. And then it's a short talk up front, and then we'll do a case presentation. Hopefully we can have a few volunteers kind of go through a case. If I'm talking too fast or if there's anything you don't understand what I'm saying at all, just raise your hand. I can stop and I can either slow down or just kind of repeat what we just talked about. And it seems like you all kind of at different stages of your training? Are all of you in the diploma program right now? Okay. And are some of you graduates of the program? Everybody's in the program. Yeah. Okay, currently cool, awesome. So let's get started here. Just kind of a brief outline of what we'll be talking about today. First, we'll just go over some definitions of terms that we're going to be talking about. And then we'll go over the clinical features and kind of most importantly, the buzzwords or the very specific clinical features that might make you think of a disease process. And then we'll go through our differential diagnosis. I think as we all kind of know at this point, the differential diagnosis for diarrhea is huge. There are tons of things that can cause diarrhea, but we're going to kind of focus on isolated diarrhea without a lot of other features. And then we'll talk about diagnostic tests that we should be getting in patients with diarrhea and how their clinical features might determine which diagnostic tests we'll get. And then we'll talk about interventions, things we can do to help these patients in the emergency department or we can send them home with. And then we'll talk about disposition, meaning should these patients get sent home or should they be brought into the hospital for observation or further management? And I think that's kind of a nuance. There's no perfect answer for that question, but we'll talk about those nuances. And then we'll go through the case. Um, So this I didn't actually know like the actual definition of diarrhea. So it's increased frequency of bowel movements or defecation. These are usually patients that have over 3 bowel movements a day. And those can be watery or bloody or just larger volume than normal and more frequent. Um, and I think the frequency and the volume and character all kind of determine which path we go down in terms of our differential diagnosis. Um, and then there's hyperacute, so symptoms that started within 1 to 6 hours of just started before they presented to your emergency department. Or there's the patients that have gone, had this for 3 weeks and it's kind of been this slow process instead of a sudden acute process. And then the term gastroenteritis, I'm not sure what that would translate to in Vietnamese, but I feel like in the US in our emergency department, this is a term that gets thrown around a lot. And we basically use it for patients who have abdominal pain that we don't have the answer to and say, oh, they must just have a gastroenteritis because we just don't know what to actually diagnose them with. And that's diarrhea with nausea and or vomiting. And I feel like that can account for, 50% of patients in the emergency department. Everybody seems to come in with this. And then dysentery, that would be diarrhea with blood, mucus, or pus. And that would kind of lead us down an entirely different diagnostic pathway. And then if you hear the term invasive diarrhea, that's just synonymous. It means the same thing as infectious diarrhea. So clinical features, I feel like these are questions that whenever I have a patient with diarrhea or bloody diarrhea or whatever it may be, these are questions that I try to ask every patient. And some of them, if they say yes, will like narrow the differential diagnosis kind of greatly. So it can be really helpful. As far as pertinent history goes, if the symptoms started within the last 6 hours, say they were feeling totally fine, and then 1 to 6 hours ago they had acute onset severe diarrhea, that would really point me down the pathway of food poisoning. Um, and does it resolve with vaccine or not? This is actually something that I haven't asked a ton of my patients, but in doing research for this talk can be helpful. This can tell you if it's osmotic versus secretory diarrhea. So that meaning if they're eating and drinking things, that means pulling water into their stool versus if they're not eating or drinking anything and they're continuing to produce diarrhea, that could be a more secretory diarrhea. And then if patients are having large volume stools, that can put you down the route with more infectious causes such as salmonella. And then in patients with bloody stool, that's a helpful hint. And I think the character of the blood is can help us a lot, whether it's just blood in the toilet bowl around the stool or if it's actually blood in the stool itself. Blood in the toilet bowl kind of making you think more along the lines of like a patient with just hemorrhoids or an anal fissure, whereas like blood in the stool might make you think something like inflammatory bowel disease like Crohn's disease or ulcerative colitis, ischemic colitis, mesenteric ischemia, or Campylobacter E. coli infections and things like that. And if patients have profusely watery diarrhea and they're really having trouble keeping up with their hydration status because they're just having so many watery stools, that can make you think cholera. And then I think fevers is an entirely other thing as well, especially fevers along with bloody diarrhea that can make you think inflammatory bowel disease. Is this an autoimmune process that's happening to these patients? Or do they have a serious bacterial infection leading to hemolytic uremic syndrome or bad traveler's diarrhea? And then abdominal pain. I think if somebody has diarrhea and it's severe abdominal pain, that would kind of point me away from an infectious cause and more down the route of an inflammatory cause, such as ischemic colitis, mesenteric ischemia, or inflammatory bowel disease. Have people traveled recently? I think this is really, really depends on where you're practicing as well. Diarrheal illness is more endemic to your area or not. That can be helpful as to what you'll be treating these patients with. And then if they've been exposed to fresh water, done freshwater swimming, the parasitic infections such as Giardia. And then they use recent antibiotics. In particular, have patients been admitted for broad spectrum antibiotics like Zosyn or they've been on ciprofloxacin, something that might kill off the gut bacteria and allow a C. diff infection to kind of set in. And then lastly, are these patients immunocompromised? And what's their HIV status? If they have HIV, are they on medication for HIV? Or if they're on chemotherapy, things like that, will make you think of kind of more rare causes of diarrhea, such as cryptosporidium. The physical exam is really important. In particular, obviously, the abdominal exam. I think if I have a patient come in with just diarrhea, I'm not expecting them to have a ton of abdominal pain. If they come in and they have severe abdominal pain when I press on their belly, if they're jumping off of the bed or wincing in a ton of pain, that's really making me think away from the infectious causes of abdominal pain and making me think again more along the lines of colitis, like inflammation in the bowel, like mesenteric ischemia, ischemic colitis. Thyroid masses is actually something that I didn't think about before doing my research for this talk. Patients with thyrotoxicosis, high levels of TSH, they're going to be having a lot of diarrhea as well, and checking for a thyroid mass could be important if you kind of go down this pathway and don't find another cause of their abdominal pain. Other kind of pathognomonic things, you can see the constellation of symptoms of oral ulcers, erythema nodosum, so the rash, kind of what you see on the anterior surface of patients' shins. They have episcleritis, inflammation around the eyes, and anal fissures that can point you toward a new diagnosis of inflammatory bowel disease. In particular, patients kind of in their teenage years, or if they have a biphasic distribution kind of later in life in their 50s and 60s. Other kind of pathognomonic things, joint pain, conjunctivitis, urethritis, these can all be suggestive of reactive arthritis. And this can happen with a lot of the infectious diarrhea that you can see. It's such as Salmonella, Campylobacter, or Yersinia infections. And I do think I do a rectal exam on most patients that come in with diarrhea, and particularly if they feel like they've been constipated before or if they've had blood in their stool. And I know this is nobody's favorite exam to do, but it can be very helpful. For instance, I had a patient come in with bloody stool about a week or two ago, and I did a rectal exam. And my whole finger was covered in blood. And he had been on anticoagulant medication. He had actually had a bleed in his colon. We ended up getting a CT scan of that, and that showed an active bleed into his colon. So I feel like that was very helpful to me because he didn't really give me a great history for that. And that was kind of a diagnosis made on my exam. And it can be helpful to use a YAC test, so an occult stool test if you have those in your emergency department. You can look for blood in the stool that isn't as obvious as the scenario that I just described to you. Since we are all studying emergency medicine, I think red flags are one of those things that we always think about in every patient. You know, when you have a patient come in with diarrhea, what are the red flags that should sort of tip you off as to this patient being pretty sick and not just like a standard infectious diarrhea patient that you can give some fluids to and send home that day. Certainly if they show signs of shock, so if they have low blood pressure, if their heart rate's fast, it's going to make you think that either this patient has sepsis or they've been losing so much volume that they're to the point where they're volume depleted and hypovolemic shock. Recent history of antibiotic use, again, that's going to kind of point you down the path of a C. diff infection that's not going to really resolve itself without you giving them antibiotics. And a lot of those patients could get admitted to the hospital based on how severe their symptoms are. Recent hospitalization will kind of make you think the same thing. If they did receive antibiotics, if it's grossly bloody, like I just talked about, it could be a more severe form of diarrhea, a more life-threatening form of diarrhea. And with patients with high fevers, I wouldn't expect someone with like a norovirus or a rotavirus, kind of the more classic viral diarrheas that we see every day that have a high fever. That usually does not happen. And as we all know, patients under the age of 65 are just at a much higher risk for bad disease of any kind. So if a patient comes in with a lot of diarrhea and they're having, 5 to 10 bowel movements a day at home and they're over the age of 65, that's a patient that I'm going to be more worried about and potentially admit to the hospital for at least observation if we don't come up with a diagnosis. Symptoms lasting longer than 1 week. Those viruses that I just mentioned and kind of the more simple infectious diarrhea, they should resolve themselves within a week's time. So if you hear that it's been going on for longer than a week, just make sure you think a little bit more broadly about what might be going on. And then, like I said before, severe abdominal pain is not typically something we see in the more in the less severe forms of or causes of diarrhea. All right, so the differential diagnosis, I tried to really narrow this down and kind of create a branch point for you. So when you have a patient coming in with diarrhea, I think the first thing you want to think about is this an infectious cause or is this a non-infectious cause? And that'll kind of split your differential diagnosis in half. And sometimes that's hard to do, but sometimes it's not kind of based on their presenting symptoms. So I think the most common causes of infectious diarrhea that we see are norovirus and rotavirus. These are simple viral infections that should resolve themselves within a couple days. Most patients will come in and you can give them IV fluids, give them some oral fluids, and they're going to be able to go home. But then you get into bacterial infections, and that's like E. coli and Salmonella and Shigella. Those can cause more severe forms of diarrhea. They may present with fevers, they may present with bloody diarrhea. Those are patients you need to think a little bit more about and really think about whether they're safe to go home or not. And then parasitic infections such as Giardia, Cryptosporidia, and Microsporidia. And then non-infectious. And like I said, the differential for this is huge. I know this is a very broad topic, but I think the things we think about are GI bleed, I've had plenty of patients with diarrhea from appendicitis. They just kind of get inflammation in that area, and that causes some diarrhea and sometimes some vomiting. Mesenteric ischemia, and it's kind of the classic. They're in a ton of pain, but you press on their belly and the belly's pretty soft, and it's a little confusing as to why they're in so much pain based on their exam. Ischemic colitis is going to be in our older patients with peripheral vascular disease. And diverticulitis, I feel like we see this every day in the emergency department, whether we're able to obtain CT scans or not, or just simply treat people with antibiotics for this. Adrenal crisis can cause diarrhea that typically isn't on my differential. They typically have other problems going on if they're in adrenal crisis. Thyroid storm, and then exposure to toxins can cause diarrhea or withdrawal from toxins. Say, I don't know how much opioid use you all have here in Vietnam, but it's certainly a huge problem in the United States. So if people are withdrawing from opioids, they can have bad diarrhea. And then antibiotic use. So diagnostics are important, and I think this is kind of tough as well. And it certainly comes down to what your resources are and what's available to you at the hospital. But I think the main take home is that most patients that are just coming in with diarrhea are not going to need any. I think in the United States, we're very lucky, and sometimes it's kind of a hindrance. It's a little too easy to get a CT scan sometimes, and I think a lot of people are just get a CT scan if they come in with diarrhea and a little bit of abdominal pain. But for most of these patients, we really don't need a CT scan to help us diagnose what's going on, or at least narrow it down to non-emergent causes of diarrhea. So I think for all patients that come in with diarrhea and just not feeling well, a very simple thing to do is just get a CBC and a CMP. And this will help. I mean, I think if their white blood cell count was incredibly high, you know, if it was like 18 or higher, that would definitely make me more concerned. And then I think the CMP is really important, in particular for our older patients, because if they have so much volume loss to their stool, they can have acute kidney injury. Say their creatinine goes from like 1.2 to 2.1 or something like that, and someone who's 65 or like an older, more frail patient, that's going to make me more concerned, and make me think about admitting them to the hospital. And then other labs that are really helpful and important, but unfortunately, based on your hospital system, and I know with ours, our GI PCR for the stool culture is not going to come back same day. This is not a test that I'm going to be able to give the patient the answer at that moment when they're in the emergency department. But this is going to tell us if the patient has C. diff, if they have a Campylobacter infection, a salmonella infection, Shigella, or cholera. And these are often tests that unfortunately we have to follow up with our patients for and give them a call and say, hey, you have a C. diff infection or you have a cholera infection, we need to treat you with antibiotics. In the stool oven parasites, I think if people are traveling or if they're been exposed to fresh water, I'm going to do a oven parasite and look for Giardia, which is probably the most common here. Or if the patient has HIV/AIDS, and I'm concerned that they may be having cryptosporidium, which is an AIDS-defining illness, and Entomobacter silitica. So like I mentioned before, imaging, the bottom bullet point there, it's usually not indicated. I think the big distinguishing factor between patients that I'm going to get imaging for and not imaging for is abdominal pain. If a patient comes in with diarrhea and I press on their belly and they're really tender, those are patients that I'm going to get imaging for. You know, if they're really severely tender, it's, you know, in the left lower quadrant or something like that, CTA is something you can think about, especially if they have bloody diarrhea. That can help you with things like mesenteric ischemia, which I know is incredibly rare, and I'm not sure if I've seen a really severe case of mesenteric ischemia. But that's always on the differential for these people with abdominal pain and diarrhea. Like I mentioned before, indication for these labs. So for the GI PCR, recent antibiotic use, if they have bloody stool, if they're febrile when they come in, if they're severely dehydrated, these are all reasons that I would give the GI PCR. In the oven parasite, these aren't typically going to clear themselves. So if it's been going on for more than 7 days, untreated water, or if they're immunocompromised in any way. So interventions, oral rehydration, I think for majority of patients that come in with diarrhea is the way to go. I mean, and this also really depends on the resources available to you in our emergency department. I think we're fortunate enough that we can give most patients IV fluids, and that's not going to be a big hindrance. So I'd say most patients that I have that come in with diarrhea that don't have a contraindication, say they don't have bad heart failure, I'm usually going to give a liter of IV fluids too. It's at least going to make them feel better. But then before they go home, or instructions on when they go home, oral rehydration is kind of the key. What I typically tell patients is take a bottle of Gatorade and a bottle of water and just dilute it 1 to 1, and that's going to be the best way to hydrate. You don't want patients to just be drinking plain water. That rehydration method with salt, sugar, and water is going to be a much more effective approach. And then there's things to help with the symptoms themselves. You can give someone Imodium or loperamide. However, this is contraindicated if somebody's having, they're febrile, have large volume stools. You really don't want to trap whatever toxins are in there if they have a bad bacterial cause of their diarrhea. And then bismuth is another option. And this can be helpful in patients that have contraindications to loperamide that we just talked about a moment ago. So I think kind of the crux of this talk and the difficult point that I always come to with these patients is, should I be prescribing antibiotics or not? Who should I be giving antibiotics to? And I'd say it's kind of the majority or the minority of cases that I'm going to give antibiotics to. Because most of the cases of just plain diarrhea are not from a bacterial cause. And these indications that I list here, these are relative indications, so it's not a hard and fast rule, but these are all reasons to make you think, okay, maybe I should give this patient a round of antibiotics, at least see if it helps them. So if they've had recent travel, if they're having a lot of diarrhea per day, if they're having more than 8 stools per day, if they're hypovolemic on exam, like if they, come in and they're a little bit tachycardic, or if they have a little bit of an AKI, and if it's lasting longer than a week, if they're immunocompromised, or if they're toxic and purine, obviously, I think the patient comes in and they have some signs of shock like hypotension or tachycardia, I think a round of antibiotics, even if you're not sure what the cause is typically not going to hurt them. Has a good chance of helping them out. And the medications that I would jump to first, I think the first one for traveler's diarrhea would be ciprofloxacin, like a simple fluoroquinolone, or levofloxacin. Bactrim can also be helpful. And I was looking through a chart, and this is all kind of based on region of the world. So traveler's diarrhea from Southeast Asia, people typically recommend azithromycin for, which I was unaware of before I started doing some research for this talk. In disposition, like we talked about kind of briefly already, can this patient tolerate oral hydration? I think if a patient is older, a little bit more frail, I'm going to have them drink fluids in the emergency department, make sure they can handle that well, feel a little bit better before I send them home. If patients have bad heart failure, if they have bad kidney disease, those are reasons that I would bring them into the hospital as well, because I think they're probably at higher risk for getting worse at home, even with instructions on oral rehydration. If they have signs of end organ damage, the most common of which being an AKI, if they have a creatinine bump, I'm going to want them to come into the hospital, and we want them to get IV fluids, and I want to see that creatinine come down before they get sent home again. Obviously, if a patient is septic, you're not going to send them home. I guess that depends on how severe the sepsis is. I know sepsis is kind of a broad definition at this point, but if they're truly septic and showing some signs of shock or end organ issues, then you would certainly be bringing them to the hospital. And then honestly, vital signs as well. If I have a patient who comes in and their labs look normal, but they're still tachycardic, their heart rate's like 115 or something like that, 120, despite some fluid resuscitation, especially in older patients, I would think twice and say, hey, why don't we just bring them into the hospital for 24 hours and make sure their vital sign abnormalities resolve and they start feeling a little bit better before they go home. And that's kind of the end of my talk. And I know that's very broad, but I thought I'd kind of leave it open for questions at this point. If you guys have any, and what's your approach? And then we'll go through kind of the case next and then talk about some take homes at the end. questions or anything? Scott and Jane, do you guys have any other input or anything to add?
Um, I guess I would be curious to know if our colleagues do specific tests in their practice for diarrhea or what are some common organisms they might see over there.
Yeah, do you guys often send GI PCRs or ova and parasite samples to the lab in patients with diarrhea? What's been your practice? Yeah, yeah, I totally agree. And I feel like I kind of feel like in the US, despite having a lot of resources, it's kind of the same way. It's this test that I'm sending that I'm never going to get back. And hopefully, if it does come back, they find the results. So I feel like we're often treating people empirically if we have a large enough concern for them having C. diff or a bacterial cause of their diarrhea. You guys kind of feel the same way with the GI PCR. It's kind of this like test that goes off into the ether and you never hear about again.
Yeah. I mean, I know I order it and I don't follow up with it. I have their PCP follow up the results.
Yeah, I agree. Or I send them home with it and they can do a stool sample at home and bring it to their own lab. I've done that quite a few times.
Yeah, I think that's one of the hard parts as well. And you guys have probably experienced that. If you want a stool sample is not exactly an easy thing for a patient to produce while they're in the emergency department, unlike a urine or something that most people can give you. So we often send them home with the cup and they'll take the sample themselves and bring it to the lab. We'll move on to our case presentation. Kind of a brief one-liner about our case. This is a 14-year-old male with a history of asthma who presents with abdominal pain and diarrhea. I was wondering if I could have a volunteer kind of walk through your approach to this case. And granted, this is kind of a difficult case, so I'm not expecting someone to like jump to the answer. But we could also kind of go through it all together. Cool. All right. So what are your kind of what are your first steps on like initial evaluation of the patient?
Where exactly is the abdominal pain, how many times at the volume is there?
Yeah, totally agree. Um, but and to kind of take a step back, even further here. Um, we have some vital signs here. Is there anything that jumps out to you about the vital signs? Yeah. And so he's mildly diaphoretic, but he's interacting appropriately. I don't know if this is the way that you all have been taught, but we do these kind of cases a lot. But for me, I'm always like, is this a patient? We call them an ABC's patient or a history patient. An ABC's patient meaning they look critically ill and we need to potentially intervene on their airway, their breathing, or their circulation. Um, and that all kind of looks normal for this patient. So I think, like you mentioned, we can kind of jump to history, kind of take the pertinent parts of this patient's history. Is there any initial actions that you would take for this patient?
Some food, 1 year of food, and some paracetamol to lower his temperature. I just have the buckle.
Yeah,
So the CDC.
Yeah, nailed it. That's exactly what I would do as well. So I'd place him on the monitor, place an IV. Point of care blood glucose is always like a good thing to get in anyone who like he's diaphoretic and looks a little uncomfortable. Like you said, an antipyretic and some fluids, especially for this otherwise healthy young 14-year-old. There's no reason not to give them fluids. And we kind of went through this. you asked a couple of these questions already, but just to give you more detail. So he's had abdominal pain for 5 days with diarrhea and vomiting. The diarrhea started off really watery, but now it turned slightly red. His vomit is not non-bloody, non-bilious. He's a little concerned at this point that he might be having some blood in his diarrhea. Also, his urine has become fairly dark, despite the fact that he's been trying to drink fluids and has been able to tolerate fluids okay. He's felt warm, but hasn't checked his temperature at home, but we know now that he's febrile here in the emergency department. He initially thought it was a stomach flu and then it would go away on its own, but now it's been 5 days or so and it's kind of just continuing and it feels as though it's getting worse now with the kind of red stools. He hasn't had any surgical history, hasn't had any recent travel. So what physical exam would you do?
First.
Yeah, definitely. And I think for the purposes of these patients, the abdominal exam is the main thing. Anyone who's tachycardic, I'm also going to listen to their heart and lungs just for the sake of it. But I think, like you said, the meat of it is in the abdominal exam. And since this is a case presentation, there's always going to be some like red herrings in there, kind of, things that aren't as obvious. So things that jump out, he's not in distress, interacts appropriately, his pale conjunctiva, dry mucous membrane. So this patient looks like he's a little bit volume down, it's a little dry. Heart and lungs sound normal. Belly is soft, it's not tender, it's not firm to the touch. He's not guarding when you try to press on it, he doesn't have any rebound tenderness. There's no gross blood on rectal exam and no obvious source of bleeding. And what I mean by that is he doesn't have any hemorrhoids or anal fissure that might make us think that the bleeding is coming from the anus itself and not something in his GI tract. One thing that is kind of unique is this patient has 1+ edema to all their extremities. It's a little bit odd in a 14-year-old, otherwise healthy patient. Their neurologic exam is normal. They have pale skin, scattered CPA and ecchymosis on his trunk, which is also kind of atypical for a patient that's coming in with diarrhea. And I know you said you're going into geriatrics, so this might be kind of on the other side of the spectrum, but we'll kind of work through it together. All right, so very broad. What's on your differential at this point?
Strong, so I'm almost thinking of sciatic colitis or something to do with the infection side.
Yeah.
Salmonella or Shigella. Yes.
Totally. What's kind of pointing you towards a more severe form of infectious diarrhea?
AKI because of the edema.
Maybe.
The change in his urine.
Yeah, totally. Well, what other things are kind of concerning?
Fever.
Yeah, exactly.
Also, ecchymosis strong. That would be something. So, forgetting the worst. Something with previous blood.
Yeah. Yeah. No, you are very much on the right track. So very broad. I mean, we've taken maybe a few things off the differential. I think we've taken the less severe forms of diarrhea off the differential. I think norovirus and rotavirus are less likely at this point since, like you said, this patient's febrile, he has abdominal pain, he has bloody stools. It could be parasitic, but that wouldn't typically cause these bloody stools like he's having. I think we're thinking more so either bacterial or some inflammatory cause. Or ischemic cause of this patient's diarrhea, but maybe ischemic would be less likely in a patient who's 14 and otherwise healthy. Yeah. Yeah, I feel like that's exactly, is that what you were thinking of? So you mentioned this, but what diagnostics would you get for this patient?
Labs,
Mm-hmm. Labs or imaging, whatever.
obviously you see CFD, some coagulation panel. I also want to do ultrasound of the CT, X-ray, flow of the other differential diagnosis like the status.
Mm-hmm. Yeah.
What's kidney function, CFD panel.
Mm-hmm. Yeah. What's one reason you wouldn't want to get a CT scan?
Just see the everything. First.
Yeah, I think an ultrasound would be a good choice. I think we try our best to avoid CT scans in younger patients and expose them to radiation. So exactly like you said, CBC, CMP, the GI PCR, stool cultures, those things are going to come back later. We do a Y-ACT test, and we would find that this patient's Y-ACT test is positive. We type and screen this patient as well. I feel like any patient who has a large volume of bloody stools, I'm going to order a type and screen for, just in case I do need to give them a blood transfusion in the emergency department. And like you mentioned, CT scan, probably in this patient who has, if we remember back to the physical exam slide, his abdominal pain really wasn't that severe when we pressed on his belly. That was fairly unremarkable. So I'd avoid advanced imaging. I think an ultrasound is great. And as far as medications, like you said before, I give him fluids, I give him some anti-nausea medication to lower his temperature. All right. So the results on our lab work comes back. How would you interpret this labs? Yeah. So the combination of these two things, the high total bilirubin, the low direct bilirubin, and the low hemoglobin, what is that? Yeah, so you might have like a hemolytic process going on if you have elevated levels of indirect bilirubin, low hemoglobin counts, especially on that smear, the helmet cells and burst cells. And he's got some bilirubin in his urine as well, and that's concerning for hemolysis. We mentioned all these things. You mentioned he has an AKI. You would definitely not expect a healthy 14-year-old's creatinine to be 2.3. This is his blood smear. Granted, a blood smear is, I am never looking at blood smears in the emergency department. Luckily, we had pathologists to look at blood smears for me because I would not do a good job of looking at blood smears. I think if I looked at this without knowing the answers, I would say, yeah, these don't look good, but I can't exactly tell you what's going on. But he's got some kind of abnormal red cells here, all things we've kind of talked about already. You kind of mentioned it. Oh, I meant to create 2 slides here. This is a pediatric patient with bloody diarrhea, hemolysis, thrombocytopenia, and kidney dysfunction, which immediately kind of makes us think of hemolytic uremic syndrome. What do you know about hemolytic uremic syndrome?
Zero experience.
Yeah.
I have never seen this before, even if it's a student.
Mm-hmm.
Never seen.
Yeah, it's not very common at all. I think I've seen it once in our children's hospital in Utah, and I think that's only because this is the one children's hospital that everybody kind of comes to. But the nice thing about it is it has a constellation of symptoms and laboratory findings that would kind of directly point you towards the disease process. Most cases are in children under 10, so that was a bit of a rare incident with a patient who's 14. And so the pathophysiology of this disease is you have a Shiga toxin produced by bacteria that your body develops autoantibodies against, which are also autoantibodies against CD36. This is a protein that resides on the surface of both red blood cells and platelets. So you get autoantibody destruction of red blood cells and platelets. So that leads you to be thrombocytopenic and have low hemoglobin as a result of hemolysis. And it usually, if we think back to the course of this patient's presentation, is he had diarrhea, some abdominal pain. It was really watery at first, and then that transitioned towards bloody stools and dark colored urine as he developed the hemolytic uremic syndrome. The classic triad is renal failure, thrombocytopenia, and microangiopathic hemolytic anemia. And management for these patients is really just supportive. You want to fluid resuscitate them. There's not an indication for red blood cell transfusion because if you transfuse them with red blood cells, their antibodies are just going to attack those new red blood cells that you're putting in there. However, if you have the resources and if the patient is in kind of poor circumstances, you do a plasmapheresis and essentially remove those antibodies from his plasma. And I would certainly admit this patient to the hospital. And depending on where you're practicing and if you had access to specialists, I would consult peds hematology and peds nephrology to make sure that they're kind of following this patient in the hospital as well. All right, so just to wrap things up, kind of some key takeaways from the talk that might kind of help you guys the next time you see your next patient with diarrhea. Is thinking your first question is this infectious or is this non-infectious? You know, does this patient have a fever? Or do they have bad abdominal pain? Or are they looking pretty well and just have some mild diarrhea? Fluids are usually helpful. And honestly, any patient that comes into my ED, unless they have a contraindication to fluids, I'm usually giving a liter of fluids, just at least to help them feel better. Because in these patients with norovirus or rotavirus, there's really nothing we can do to help shorten the disease process or help the disease process, but at least it's something to do to make them feel better while they're in the emergency department. Think about patients that you shouldn't be slowing down their gut if they have bad infectious diarrhea, bad bacterial infection. I wouldn't want to give them Imodium and really slow things down. Think about those patients that we want to give antibiotics to, patients that have fevers, that have had a long course of diarrhea, if they have bloody diarrhea. And imaging is really not super useful in patients with just diarrhea. It's the patients with diarrhea plus, whether that's diarrhea plus abdominal pain, diarrhea plus a bad abdominal exam. Those are patients that I might get a CT on. And then I think disposition for me, it really comes down to vital signs and labs. If the patient's tachycardic or hypotensive, I'm definitely going to bring them into the hospital. Or if those patients have an AKI and show signs of end organ damage from low volume status, those are patients that I'm bringing to the hospital and have admitted for at least 24 hours as well. And I think that is it. Do we have any questions or comments or? Mm-hmm. I feel like the most common cause that I'm sending off the GI PCR is for C. diff. Yeah, it's a panel. There was a list of things that it tested for. Yeah, so these are the things that the GI PCR is going to be testing for. And I do feel like you mentioned, most commonly I'm sending it off for patients that I think might have a C. diff infection. And these are patients that have, had a lot of diarrhea for some time and say they were hospitalized recently and been on broad spectrum antibiotics before they came in. These are patients that I'd send as a GI PCR for C. diff.
Harrison, can you guys hear me?
Yeah.
Oh, yeah, I was just going to add, we actually have a C. diff specific PCR too, where we can send off only the C. diff, if that's really the only thing we care about. And then we can also send a culture for just C. diff. The other thing I was going to add, just more generally speaking, like diarrhea is super common and we can't test everybody. with labs and PCRs or that sort of thing. So I think just good return precautions, letting these patients know like diarrheal illnesses are common, they're usually benign. But if this is not getting better in about 5 days, if you start having fevers, if you start having blood, then you need to come back because that is, indicative of something more serious. But a lot of times I'm not getting blood work in like the kind of straightforward people. I'm not usually even giving fluids in a busy ER because we don't sometimes have time, but I'm just giving them really good return precautions and instructions to go home and orally, intake a lot of Pedialyte, Gatorade, electrolytes type of stuff.
Yeah, totally agree. Questions? Well, thanks so much for listening to me. If you guys think of any other questions or anything like that, let me know. I'm not sure if we're moving on to the rush exam next, but we'll be talking about some ultrasound topics in a little bit, practicing some ultrasound on each other. So,
Alrighty, well, until next time, Harrison. Have a good time in Vietnam. Thank you everyone for taking care of him.
thanks, Shane. I will
Bye,
talk to you
everybody.
guys soon.
See ya.